Hey, everybody. I'm Ashley Blackmon. I'm a cardiology nurse practitioner at Piedmont Heart Institute in Atlanta, Georgia. And I am so honored to be here today with Alex McGrath. And we're going to talk about new tools for fluid management in acute heart failure. So, Alex is a cardiac quality department manager in the Charleston area medical center in Charleston, West Virginia. Welcome, Alex.
Hi, Ashley. Thank you guys for having me today. I am, like Ashley said, the Cardiac Quality Department Manager at CAMC in Charleston, West Virginia. Previously, the CHF Program Coordinator here in 2021, and then recently transitioned into this role. So I worked closely with our heart failure patient population, and now I work closely with not only our heart failure patient population, but our AMI population as well, which has been really beneficial to both because there is so much patient overlap in those two departments. So.
Absolutely. That's wonderful. I am a cardiology nurse practitioner working currently in general cardiology, but for the past decade have worked with advanced heart failure patients who may be new diagnosis of heart failure, milrinone dependent, and post LVAD and heart transplant. So hoping to expand in our outreach department for bringing in more heart failure patients to streamline through our heart failure clinics. So welcome everyone from joining different social media platforms. Please feel free to comment and ask questions and we'll answer them as we go along. So Alex, we're here to talk about acute decompensated heart failure. So you've shared some of your role and experience. What kind of patients do you see?
So I actually don't see clinical patients, but I work really closely with bridging the gap between our inpatient population and sending them to our heart failure clinic in the outpatient world. So like I said, I don't see them in the clinic, but I'm definitely working with our navigators, with our clinic providers, and our nurse practitioners and our physicians to make sure that that is a smooth transition for them.
Excellent. I currently see a lot of general cardiology patients in the hospital setting. I've done a lot of work in both clinic and hospital situations, but right now I'm working in general cardiology, and so a lot of patients with new diagnosis of heart failure, but also readmissions of heart failure. So, what would you say your burden of hospital readmissions at your facility is about at? And we have a slide that will show us talk about hospital readmissions.
So at CAMC, approximately every month, we have between 100 to 130 patients that are discharged with a primary diagnosis of congestive heart failure. And so those patients, roughly 25 to 30 of them will return for some type of readmitted reason, 5 to 10 of those being specifically for heart failure reasons. So it's one of the major players in our hospital readmission. So it's actually on our hospital quality scorecard. We meet constantly about it, constantly looking at different ways we can attack this population and, like I said, bridge the gap from that inpatient stay to the outpatient world, and then thus keeping them out of the hospital during that 30-day window.
Yes. And I have noticed a lot of fluctuations in our heart failure readmission rate, especially dependent on staff turnover. And so as we see on this slide, there has been a rise in hospitalizations, probably also going along with a rise in diagnoses. So in the past, for 10 years, from 2008 to 2018, the readmission rate has greatly increased, especially people of color. So Black and Hispanic individuals, if they're younger, 18 to 45, if they have systolic heart failure in men or diastolic heart failure in women, those people tend to have more readmissions noted. The projected cost is going to greatly increase, which is part of why you do what you do, so that you can help the hospitals keep from losing money because people have to come in and get IV diuretics. 1 in 4 patients are usually readmitted within 30 days of discharge. And as well as 50% of patients are readmitted within 6 months. So the clinical importance and challenge is optimal fluid management in improving patient outcomes. So we've talked a little bit about what kind of patients we see. What are some common factors in decompensation?
So symptoms of decompensation, I mean, when a patient comes back to the hospital, we're seeing that shortness of breath on exertion or even at rest. I mean, these patients are sitting in a chair, unable to breathe, typically unable to lie flat as well. Fatigue, just overall generalized weakness, some activity and like I said, activity intolerance, fluid retention, whether that be peripheral edema or that pulmonary edema, tachycardia. The body is compensating for that decreased cardiac output. So that's one thing that we typically will look for and see on most patients. Cough, whether it be dry cough or, the wet cough due to the pulmonary edema and the pink frothy sputum, nausea, loss of appetite, simply due to that congestion in the abdomen, and then the cool, clammy skin. This is just due to that poor perfusion, unfortunately, what's seen in heart failure patients.
Absolutely. Some common risks that we've been seeing is men, especially younger than 65, African American. If their first hospitalization tends to be prolonged, that is a risk for readmission. Any sort of complicating history, such as drug abuse, renal failure, myocardial infarction, or a COPD, greatly increases the risk of readmission. So we've talked about
those readmissions have more complex things going on too. So they have that renal failure component, uncontrolled diabetes, hypertension. I mean, it's not just the heart failure that's bringing them back.
Absolutely. I always look at what was the triggering factor. If you didn't miss your medications, do you have a new urinary tract infection? Did something change in your diet? Do you have now an upper respiratory infection? Absolutely. These patients very easily can be pushed over the edge with their other chronic illnesses. So we've talked about the symptoms, we've talked about readmissions, and so now we're going to go to what is the clinical importance and some of the challenges of achieving optimal fluid management that you would say in your experience?
So optimal fluid management, obviously, just maintaining the hemodynamics and the electrolyte balances for these patients, ensuring that their sodium and potassium levels are staying within that normal range. It's obviously, fluid balance is key for renal perfusion, and optimal management of that can reduce the risk of AKI, whether they're dehydrated and dry or they're overly, volume overloaded and wet. So some challenges that, are related to this are each patient has unique fluid requirements. You and I both have different, different body compositions. We both are going to require different fluid balances. It's not easy to accurately assess these patients either. So sometimes what is a fluid fluctuation for me isn't a fluid fluctuation for my husband, who's 6'4". I mean, so it's hard to manage those when you're just talking about daily weights. Patients aren't good at doing them at the exact same time. However, we have advanced monitoring techniques too that we're going to talk about, but those are resource intensive and they can be invasive at sometimes. And some of those patients don't want that invasive monitoring.
Yeah. So let's talk about when the ideal time to intervene is to prevent hospitalization. So we have early monitoring systems that we're going to talk about. And unfortunately, a lot of patients, especially new heart failure patients, don't understand what their early signs are. And even with lots of education, they still might not, even if they're weighing themselves daily, they still might not notice. So early monitoring helps us continue to educate them and help them see, with a change before it happens. So usually patients that have symptoms severe enough to require hospitalization, the changes will begin 10 to 20 days before that symptom onset. So in stable patients, they have good cardiac output. You had mentioned cold patients before. So they're going to be warm. They're going to not have any trouble breathing or doing daily activities. But anything that changes that, like we talked about those triggering events. So any sort of change in the sodium fluid balance or the neurohormonal balance, cardiometabolic syndrome is a big factor in our everyday world right now with the rise in diabetes and obesity. This affects how the renin-angiotensin-aldosterone system interacts with the body and how you can be kind of hyperactive in that state. and continue to retain fluid. And so as that fluid is retained, there's increased filling pressures, and there can be a change in your intrathoracic impedance in your lungs, and there can be a change in your weight. And those are things that can happen before we have symptoms needing hospitalization. So the good news is subclinical decompensation can be detected days to weeks prior to hospitalization. And we now have remote monitoring tools to detect this. So can you share with us, Alex, what some of these tools are?
Sure. So in our practice, we use invasive and non-invasive. So some of the non-invasive devices that we use are the HVMs, REDS. There's the body guide edema monitor, cardio tag, vital patch, and then the body port cardiac scale. So these devices are typically ordered or applied to the patients that have experienced an acute event. So they've landed in the hospital. We're trying to keep them out of the hospital for that readmission in their comfortable space. And they're, can predictably prevent that recurrent hospitalization for us. So they provide alerts to our providers that allow that GDMT or those diuretics to be adjusted in the outpatient world. And then the invasive, we all know it's the Optivol, the Optiflow, HeartLogic, even the CardioMEMS. These devices require that additional invasive procedure. Some patients may or may not be, agreeable to have that invasive procedure done. They may not even be stable enough to have said procedure done. So they allow providers to monitor the volume status, but this is more in the chronic setting. These patients have to be vetted for these implants. They have to, go through an insurance approval process. So they're typically seen more in that chronic patient population.
Absolutely. Those are excellent examples. I think one of the difficulty a lot of providers have is integrating these devices into practice. They might not know what the alert system looks like. They might not have it set up where nurses get the alert system and then they let the provider know, or the provider gets the alert. And so integrating these into our practice is important. Especially, we've also noticed that there are devices that will monitor fluid or activity that we forget to look at. So like wearable cardiac defibrillators sometimes will look at body position and heart rate. And if you don't have those alarms set in place to get notified, or if you don't have somebody that goes and checks it, it's going to be more difficult to follow through. We just got a great question. What are some of the advantages and disadvantages that you've seen with these tools, Alex?
Oh, wow. So definitely the reduction in our readmission rate. It's not been a huge reduction for our hospital system thus far, but I believe that we have around 100 patients right now enrolled in some type of invasive or non-invasive monitoring, at least that our clinic follows. And so just knowing that these patients are monitored, giving our providers the opportunity to manage them in the outpatient setting has been huge. These are patients that would otherwise have returned to the emergency room and probably been admitted for another inpatient stay.
Absolutely. We utilize a lot of both invasive and non-invasive, and we've had to set up a system where we have a designated nurse and a designated advanced practice provider looking at these alerts or getting these phone calls sent to them so that they can better triage and manage these patients in the outpatient setting. If you don't have that in place, it's very difficult to catch them before they get to the hospital.
And we have a pretty robust team here as far as navigators go, and that are willing to accept the alerts and then converse with the providers. And that's made a huge difference for us.
Absolutely. Invasive devices such as CardioMEMS has to actually have an interventionalist place them in the pulmonary artery so that they can monitor PA pressures. But the problem is that with that device is patients have to actually lay on a pillow to get the reading. And some patients are really good about laying on their pillow. Some patients are not. So it's difficult to manage patients that will not comply with actually sending the data. However, other systems such as the HVAMs, the UCAR, the REDS, these things are more like stickers or vests or things that patients can wear and get sent to a remote monitor without them having to do anything. And sometimes it's easier. You might not have exactly as accurate information, but sometimes it's easier to manage those patients because you're not having to rely on them to constantly be sending you the data. You will see, for everybody watching, you will see the QR code at the bottom. You can scan it to claim your continued education credit. And what we've seen is a lot of mixed data from all of these devices. And again, it depends on how well the providers know how to utilize them and how well the patients will follow through on utilizing them. But at the end of the day, overall, these things will, these devices tend to reduce hospital readmissions by up to 38%, specifically with the UCOR or HFAMS device. And this is big because I think that once we start getting more in the habit of utilizing these devices, we can greatly impact heart failure readmissions in the country.
Sure. So just to wrap up, I mean, as a nurse practitioner, both of us have spent a lot of time working in this patient population, and the benefits of the remote monitoring, you know, invasive or non-invasive or invasive, are obviously incredible, at least for my patient population. So just to be able to monitor the patient post-discharge for an acute event and receive more information than just that daily wait has been really beneficial for my team.
Absolutely. I agree 100%. So let's move on and see if anybody has any questions. And is there anything else you would like to add? I'm pretty passionate about this. It has a very wide range of patients that are affected. And I think that the remote monitoring devices, the options that are available, give you a lot of different ways to reach patients. A lot of them are reimbursable for all coverages, all benefits, but also some of them are, a couple of newer ones are still in the research phase. And so you can get patients that don't have benefits into some of the research trials. And then some of the devices will utilize Wi-Fi, and some of them will utilize cell service. And so depending on how what your patient has access to can also determine what works for them. So we're going to wrap up now. And thank you so much for participating in this activity. Alex, thank you so much for joining me today. I really enjoyed speaking with you.
Thank you for having me, and I hope that we'll connect in the future.
Yes, absolutely. You take care, everyone. Please be sure to scan the QR code to claim your credit and review disclosures.